Hey there, everyone. Thank you so much for coming to our panel session titled Ready Next Time, Preparing for Another Pandemic. I know you all are probably a bit fatigued talking about COVID, but we're so happy you came to join us here today. I'm Nicholas St. Fleur. I will be the moderator today. I am a health equity reporter over at STAT, and I host a podcast called Color Code, which looks at issues of race and racism in medicine. And I'm joined by my esteemed panel of experts over here. We have Jana Mazet, who is a vice provost, Grand Challenges at University of California, Davis. Jane True, Vice President, mRNA, Commercial Strategy and Innovation at Pfizer, and Barbara Main, Acting Director of the Coronavirus and Other Respiratory Viruses Division of the CDC. So we're hoping to have a really fun conversation here today. What I really love is for audience participation. If you have any questions, feel free to raise your hand and we'll have a mic runner come over. You don't have to wait until the end. As soon as a question pops up in your head, feel free to ask it. And I'm going to start off by asking Barbara a little bit about, pandemic preparedness versus pandemic prevention. Tell us a bit about the differences between the two and kind of, how you focus in on both of those.
Yeah, thanks. I think it's a really important question because you can do different things for prevention versus response. So the way I think about it is that in order for a pandemic to start, the first thing that has to happen is that this new pathogen gets into that first person. And that could come from an animal, it could come from a lab problem, it could, God forbid, come from an intentional bad actor, but that's the first thing that has to happen. So there's things we can do to lower the risk of that. And then the next thing that has to happen is it has to spread. And there's things we can do to reduce the risk of that, like early detection, early reporting, early response. But then if those don't get us there, then there's that, and it is a pandemic, it is spreading widely, then we're into the response, the massive response phase that we've all been living through for the last 3.5 years and have been talking about so much here. So that's the way I think about the sort of the stages of pandemic.
And Barbara, looking at, our most recent pandemic, the COVID-19 pandemic, was there a particular moment that stood out to you where you realized, oh gosh, this is now, in my wheelhouse. This is now, I need to be activated. I need to be, prepared.
Yeah, we all have our pandemic stories, don't we? And mine is that in early December 2019, I had been working at CDC. I accepted a position with the Bill and Melinda Gates Foundation and was about to move to Seattle to work there. On December 31st, the first ProMed email came through saying, does anyone know about this unknown pneumonia in Wuhan, China? December 31st, 2019. And then over the next couple of weeks, there was more news day by day by day. But the critical moment for me when I thought, uh-oh, was in the middle of January when there were the reports out of Germany. There was a woman who had traveled from China for business reasons, wasn't sick, had business meetings, got on the plane, went back to China, developed symptoms on the plane, as I understand, but several people in Germany got sick. And I thought, uh-oh, this is being transmitted before people are symptomatic. We might not be able to contain it. So that was my moment.
And then to Jana, tell me a little bit about, for you as well, at what moment did this pandemic become, just all too real for you when you realize, oh goodness, I need to be activated right now?
Yeah, so I spent the better part of the decade before the pandemic started working to develop the capacity to safely and biosecurely identify viruses with teams in more than 40 countries over the 10 years. But at the time, at the beginning of the pandemic, we were about 30 countries where we'd improved their laboratory capacity, their PPE, their field work to be really safe and to be able to actually not just run a kit for malaria or for some other disease that was a priority for their country, but to know how to diagnose disease X, a new virus. And so I did see the ProMed post, but it was New Year's Eve, and I had been in the place of responding to, I think, about 50 outbreaks over that decade, and so I was kind of like, let's see what happens here. So it didn't make me go, and it should have. But by the middle of that first week of January, our teams, which were country teams, not our teams, but we had been funding them and raising capacity for that decade, they were all starting to reactivate. We were done in those countries and finishing up the project, and they started saying, hey, are our protocol's going to work? Can we diagnose this if it comes into our country? The Chinese team was quiet, but we knew that they were also using our protocols. So even before we had diagnostic tests that were blessed by WHO or whatever country, they started to work. They went to work, and they were detecting and did detect in some of the countries near China, like Nepal, Cambodia, Thailand. They detected the very first case before we had a sequence, a full sequence, before we had a name for the virus, and their public health systems went into action immediately. So we also saw in Africa that they were testing, it was a little like a month later, at the borders and at airports and not finding them. So not putting all those people into quarantine and stuff, which was really, really amazing. So, so we were activated, but we were activating a network that was no longer funded by the United States of America. They were working for their countries, and for me, that was such a win. And they did a great job. But things derailed after that, sadly.
Right, and we'll certainly get there as well. Jane, tell us a little bit about what it is that you do over at Pfizer, and then what was that moment that you remember when you were activated, you became a part of, this story to help find this vaccine for this super deadly pandemic?
Yeah, thanks. So I'm responsible for the mRNA pipeline, which includes our vaccines and development, as well as we're invested in gene editing as an example. I'm also our global pandemic security lead, which it's a space that I started working in right before the 2009 pandemic. I was consulting with another company at the time. The moment for me was probably about January, February. I don't know specifically when, but I was at another company at the time. And we were a flu manufacturer. And all of us were looking at each other saying, it's not a flu pandemic. What are we going to do? What's going to happen? Can we use this technology that we've invested so much money in for a pandemic like this, for coronavirus? And so we had a lot of difficult questions to ask ourselves. I do know the Pfizer story, which is very motivating, inspiring, and I do know people were mobilizing very quickly. We instituted a new bureaucratic process that's actually eliminating the bureaucracy called Lightspeed. And it's really, the core of it is focus on what matters, reduce the layers, get to the decisions ASAP, and make sure everybody knows exactly what the priorities are they need to work on. So that was the mobilization at Pfizer. You had people around the whole world, of course our vaccines research and developers, and all the way up to the CEO level, working on this as a critical priority.
So we just talked about all of your kind of first days there, that moment where you first became activated to this. Knowing all of that, knowing what you went through, how do you kind of wish those first days were? Or how can we better prepare for those first moments for the next pandemic? I'll start with you, Jana.
Oh, so you've picked a passion point for me, because I work while I was funded, and I was actually, that project I mentioned is called the PREDICT project, funded by U.S. Agency for International Development. At the time was the largest global health security project supported by the United States. And I had been arguing for disease prevention and preparedness, as had all of the teams. And what was so frustrating to me was I had been integrated into the systems with the countries where we were working, and in our own home country, I had no on-ramp to help here. And was even calling colleagues, friends, like, we are doing this work in our laboratory here with trained people, but we did not have the ability to, so I use this anecdote, one of my lab technicians' grandma was really sick, and she was testing samples from people in Africa, and she couldn't test her grandma legally. And that went on for months, and we were losing lives, and we were losing the ability to tell communities that they were safe, that it wasn't there yet, or that it was there and they should be safer by staying home or wearing masks or whatever. So for me, finding an on-ramp for the private sector and for academia where so many resources were available and people were sitting home going, let me help, let me help, let me help, but we couldn't help because the system, which is still the same system today. There were a lot of emergency authorizations that went in that allowed us to help test the whole county, test all the school children, but the system didn't allow us to help for months, and we haven't fixed that yet.
Jane, any other insight into that? Jana just brought up, that on-ramp for the private industry. What are your thoughts there?
Yeah, I spent a lot of time over the last couple of years talking to governments and other companies and NGOs, and one of the key themes coming out of these discussions is we had a pandemic playbook, and unfortunately, we had to throw that out the window at the very beginning. So a lot of the discussions right now about being ready and the on-board for next time, the on-ramp for next time, is about let's put some guiding principles around our response versus step-by-step actions, because the step-by-step actions rely on, okay, we're going to follow it precisely. Well, what happens when one of those steps doesn't happen? Do you skip it? How do you make a decision around that? What would you do differently, right? So now a lot of the focus is on, again, guiding principles around the response versus actual specific steps.
So Barbara, as Jane just said, had to throw out the playbook there. So what do we have to do when we're preparing for the next pandemic? Should we be making a bunch of playbooks? Should we be making it more flexible? What are your thoughts there if, all the work that we had done going into this pandemic, really, we had to really shift and we had to pivot at so many steps. How can we really prepare for the next one?
Yeah, I think that there's so many lessons learned out of this pandemic. I think from a purely sort of public health point of view, critical importance of data, fast, complete, common operating picture. It took a while to stand that up. We're trying to sustain it for this country. And there's a lot more that could be done to make it better. Secondly is flexibility, the importance of partnerships, of existing sort of agreements. I mean, all of this kind of bureaucratic, uninteresting stuff, totally unsexy stuff, like having contract mechanisms in place that can, be turned on when needed, to have that ready to go, so that you have that warm base, so that you can surge.
Right.
Starting from zero is really, really hard. And I think we saw this all over the world, that where countries had something that they could pivot and surge from, they did well. And when they were starting from nothing, that it was very, very difficult. So I think that concept of a flexible, warm base, we talk about the the cycle of panic and neglect in public health. And there is, I think, a cycle of surge and then prepare, surge and prepare, but it shouldn't be panic and then ignore, panic and ignore.
Right. And I'd love to ask the panel, what were some other obstacles that had to be overcome that you hope aren't obstacles we have for the next pandemic? What are some of the, some of the low-hanging fruit here that, gosh, I can't believe we had that obstacle in there. Looking back on it, it's so, dumb that that was a barrier to what we needed to get done. I'll start with you, Jana.
Ooh, well, following up on what Barbara was saying, there are a lot of regulations in public health that are great, and they were put into place for very good reasons to make sure we all get great health care. They don't work at all in an emergency response, especially this kind, for a disease X that we don't know about. So there are laws and regulations that need to be fixed. And one's CLIA, right? So that's the one that didn't allow our laboratory technicians to do testing. In fact, where I live in California, whole counties didn't have a single CLIA certified officer. And the universities became that and got that, that authorization. But we didn't have a public health system that had enough epidemiologists that were trusted that could do this. And I totally agree with what both Jane and Barbara said. It is completely feasible to maintain the trusting relationships that we have now put into place and have those groups continuing to get together and put in contingency plans, they need to be codified. And that's my worry. I don't see that happening, and that probably is the low-hanging fruit. Like, we are developing guidelines, kind of like you were saying, for the academic community to say, if you want to be involved next time, think about all these things and lead with equity and work from a place of trust. And you can't do that if you don't work on that ahead of time.
And Jane, what about the obstacles that you may have seen that you felt, next time we have to make sure those obstacles aren't in place? I mean, we saw the development of the mRNA vaccine, and then we saw shots into arms at record time, really. But we also saw a lot of, a lot of pushback against that. A lot of people knowing that we had a vaccine that, helped prevent this bad effects from the disease, and people weren't taking it as well. That sounds like an obstacle to me, but what were some other obstacles?
I mean, there's a lot to unpack there. Yes, so we did have a vaccine in record time. It was something like 284 days, which is, you're taking a 7 to 10 year process and whittling it down to that. I will say we had really wonderful partners at FDA and CDC that were reviewing data on a rolling basis that was allowing some of that quickness to happen. We are, of course, working on how to get done faster the next time. So I think we should all be hopeful that the next time we are not starting from scratch with a technology like mRNA. And if anything's an example, you take last year when the FDA decided on what that COVID vaccine needed to look like last June, and we had product in market in September. So there is a way to get there, and I think actually it will be less of an obstacle next time. Vaccine hesitancy is a huge obstacle. We need to figure this out. This is, I know Secretary Becerra was talking about, equitable access for medicines. This is one of the, we collectively as humanity just went through an experience. And for the most part, everybody in the world had access to an almost free vaccine. And you still had people that didn't want it. And what is going on there? I think we have to figure that out, and I think it's more than just mandates and trying to share data. I think it has a lot to do with human behavior and psychology, and I think we need to bring that into the equation as well.
So what is the lesson from that?
We still need to garner trust. We still need to build trust. We need to have a level of transparency so that people understand, what it is. I get it. You want to know what's going in your body. I'm with you right there. But there's got to be different ways to make sure that people understand that this is not just for you, it's for your family. It is for you if that's what motivates you. It's because it is required if that's what motivates you. But I think we have to get down to what's driving that. And then, of course, the dirty word that we don't want to say and talk too much on is politicization of health choices now that's happening, and not just our own country. It's not just our own country.
And I definitely want to dive into politicalization of the pandemic, of the vaccine, of mask wearing and all of that. But before I do, I want to ask, does anyone in the audience have any questions? Oh, we have one right there. The woman in the hat. I see several questions. We'll go to her first. We have a microphone coming. 1 second.
I've believed in the vaccines, and I've had 5. Now, boosters, 4 boosters in the original. Anyway, I heard that there's going to be another one coming out in the fall. How can you be sure you're getting the 6th one if you go and not getting a duplicate of what you had previously? And also, does that cover all of the variants? And is there a new variant you're suspecting, and that's what you've got in this latest one? I just would like information on number 6.
I would imagine that is for you, Jane.
I'm happy, but I've got some scientists here as well. So coronavirus is a virus that we know mutates. So there will continue to be variants. Therefore, before SARS-CoV-2 and SARS-CoV-1, there were 4 circulating human coronaviruses that only emerged in the last 200 years. So we know that it has the ability to mutate and reinfect. With that said, FDA looks at a lot of data to determine what needs to go into that vaccine and how it's going to protect, in the US, Americans the best. So I think they do the best they can with the data that they have, and the data is as robust as we can have it be.
Can I add?
Yes, please
that's
jump
great.
in.
And so what I think it was last week, just last
Yes,
week,
they picked it.
that FDA's advisory committee met, and they voted to recommend that FDA include just the XBB type strain, which is what's circulating now and is expected, where there's nothing else on the horizon at this moment. And once that vaccine is available, none of the others will be available. So you can be confident that you're getting the current one.
And if you have any doubts, ask. Ask.
And Chana, you wanted
Well,
to
I just wanted to
jump in.
pivot a little bit here. So we have identified, just in that project, 188 new coronaviruses that are out there circulating. So we know of about 8 in humans that make us sick, but there's just a plethora. We were only scratching the surface because we were really building capacity to detect, not trying to catalog everything. So that's not supposed to scare you, but what that means is, I didn't bring it up as low-hanging fruit because it's not low-hanging, it's expensive. But we can know every virus that's out there. We can know that, and then we can track the top 100 or whatever we think is most important. We can even do it pretty non-invasively. Now we have methods like sewage that we can monitor to be able to do this. We just need to use the platforms. That's kind of where I'm talking about the government, private industry, academic collaborations can do that pretty easily, and we can detect changes. We can detect changes in the ones that we know about, and we can find the new ones. It really only costs about $4 billion to do that. Now that sounds like a lot of money, but $4 billion compared to living in isolation, millions of people dying, trillions and trillions of dollars. Yeah, it's something we were advocating for before the pandemic, and it didn't get traction. I'm hoping now countries will all chip in their own amount and do it in their own countries, and we'll be much, much better off. So you don't have to feel like you have to have a vaccine for everything.
And Jana, before I go to our next audience question, so what are the diseases that are on your radar right now? What are you looking at? Again, not to scare anyone, but what are you focusing on right now?
I used to get asked this before the pandemic. I try to refuse to answer because what I'm worried about is we only look at what we've just experienced. We are always doing that, looking over our shoulder. Oh, now we have to be ready for that one. And we're not looking forward. So nature tricks us, right? Nature brings us new things. So what I think is that characteristics that make diseases spread rapidly, human to human, and difficult to control is where we should focus our attention. So coronaviruses, sometimes, well, multiple modes of transmission, but those things that can be aerosolized and transmitted person to person in that way and cause respiratory disease that allows it to really go easily between people, we need to look at that. And then I like to prioritize viral families. So influenza is not a family, but I'll put it there. We need to keep on top of that. We need to think about the coronaviruses. Paramyxoviruses, that's where measles comes from. Some Bunya viruses. So there are things that we know about, and working with folks like this and other international and not-for-profit organizations like CEPI that some of you may have heard about, we're working to actually optimize the risk ranking and then the vaccine pipelines so that we can get to a vaccine preferably in 100 days. You think we can do it? I think we can.
I mean, I would bet
Look
on
what
Pfizer.
you did.
but
Yeah, you did. And I too have 5 Pfizer vaccines in me, and I will keep getting them every 6 months until we know we're in the clear. Because that was another big miss that everybody said, oh, telling the public that it might once a year, and I was like, no, coronaviruses don't last. Your immunity doesn't last a year. So they're just, again, it's that combining what I've been dedicating myself to a One Health approach. So bringing all the disciplines, all the sectors together so that we learn from each other and make a better plan. And that's not hard.
Yes. I also have several Pfizer shots in me and some Moderna as well. Yes.
Can I chime in again? And I have both too. So I think that, and the other thing that I think is very, I totally agree with respiratory spread is what we're most concerned about. And then pre-symptomatic transmission or asymptomatic transmission.
Yes, absolutely.
I mean, the big difference between SARS back in the early 2000s and this was that people didn't really transmit SARS-1 until they were sick.
Yeah.
And so you could screen for fever and control it, contain it. But with this, as we know, that's not the case. Too much transmission early on. The other thing I wanted to mention is I totally agree with you, Jana, that you know, I love the term disease X. I mean, we should be preparing for disease X at CDC. We talk about disease agnostic systems, and it's, you know, no matter what it is, we're going to need data. We're going to need workforce. We're going to need communications. We're going to need partnerships with academics and, you know, across the government. We're going to need excellent global support. So we can put those systems in place without knowing whether it's A, B, C, or D.
Yeah, absolutely.
Questions? I saw one. This gentleman over here.
Thank you all. I'm David Sandman from the New York Health Foundation. You have focused mostly on the scientific and technical aspects, but to the question of will we be better prepared next time, it seems to me that we'll be worse prepared due to the erosion of public trust. You know, opinion surveys show that the CDC's reputation, you know, has been devastated. People don't trust public health guidance anymore. You know, active promotion of misinformation, you know, and people are completely sick of it all and don't want to listen to anything anymore. So, you know, it's not easy to rebuild a PPE stockpile, but that seems so much easier than rebuilding the trust stockpile. So in terms of those aspects of being better prepared with a public that's kind of exhausted and tuned out, you know, what should we be doing on that front?
I love that question, and I love the way you put that. So to the panel, how do we rebuild the trust stockpile?
I think maybe the best answer I can give you is I don't know. I'm very concerned about our entire national discourse, and not just limited to public health or to the pandemic. I do think at CDC is doing quite a lot of work to make sure to try to. I've heard it said that health communications is the single most important public health intervention, and I really believe that. And I think that CDC could have done a much better job. Not just CDC, all of public health could have done a much better job of communication during this pandemic. But I was kind of hoping that people in the audience who are, I know you're from a wide variety of backgrounds and probably people with great ideas about improving health communications. I don't know if there are ways where, some sort of external seal of reliability could be, I don't know what the solution is to that. But I think that public health needs to do better, and I also think we, as a society, need to be addressing the kind of currents or headwinds that, to me at least, are really blowing in a very difficult direction. Others? Okay.
All I would say to that is we will continue in the manufacturing world to be as transparent as we can with the data. There are lots of rules about what we're allowed to disclose and not disclose. It cannot be misleading. It cannot be, skewed toward one way or another. So we will continue our commitment there. I think, as a consumer of data as well, I would say you have to be wary of where you're getting your information from and which sources will you trust and which sources will you not. But to what Barbara was saying, it's a really challenging problem, which is why there isn't a solution to it right now.
So I agree with my colleagues here. I also think there are short-term and long-term issues that we need to deal with on this. So during the pandemic, I switched from writing scientific papers that work for my job and switched to podcasts because that seemed to be a method of more interesting information. Now I'm boring, though, because I'm not funny. I don't, say outrageous things, and that's a problem. People who are careful about the information tend to be pretty boring. Sorry, ladies, I don't, But so I think we need to find a way to get sexy with science. So I think that's really important, so that people at least pay attention. Then I think it's on all of us to actually engage. When you see somebody spreading misinformation, disinformation, you could say, oh, well, that's nonsense. Or I'm going to look that up. Is that real or not? But I believe that a huge portion of that audience in social media just swallows it, especially if it reinforces what they want to believe, right? And nobody is really coming out in the way that those people come out and countering that, right? And that's hard to do. You put yourself out there. I've received a lot of hard stuff, and I'm not putting my words where my mouth is. Really, I'm off social media because of it, because of death threats and things. So there's a short-term problem of accountability in social media that needs to be addressed. Another one is that One Health approach. So we need to work more with communicators, right? We need to stay friends. So we need to work with communicators, anthropologists, social engineering kind of understanding academics. And then the longer term one, I really believe that we need to change the way we teach science and science literacy in the school system. So we teach students to memorize photosynthesis. Heaven help us if you had to teach your kids or help them get through the Krebs cycle. Who cares? They can look that up on their phone, right? What they need to know is science is iterative, and that when things change is because the science just showed us something new, not because that we were wrong, right? And that needs to start in, primary education. That's longer term, because that takes generations.
Right. And to your question, that's something I'd love to talk a bit about, the politicalization that we saw of this pandemic, that we saw of mask wearing, that we saw of the vaccine as well. Starting with you, Jana, we had been talking about this, and you really faced kind of the brute force of this on many levels. You had mentioned that the FBI showed up to your house and that the CIA at one point was involved. Talk to us a little bit about what the politicalization of this pandemic, the impact that has had on you and your work.
Well, I changed jobs twice. So that's the impact on my personal life and work. But I didn't do that because I was running away. I was trying to do what the gentleman suggested, like how do I get involved in a different way so this never happens again? I didn't want to do this. The President of the United States sent his people after me. And that is powerful. Right? That the amount of power that our leaders have, whatever country you're in, when it's become a nationalized and politicized conversation, it has nothing to do with public health. It has to do about firing up your constituents. That is hard to fix as a boring scientist. Having a lot of lawyers in my life telling me I'm living a Homeland episode is not fun. And all for what? Because you discovered things and you tried to get people to change and you did stuff like this. So here I am doing it again, and you're recording it, so now I did it. Darn.
And then same to you, Jane. Tell us a bit about the impact that the politicalization has had on the whole, getting vaccines, getting shots into arms, and what we can learn from that.
It's really disappointing. One thing, if you were asking a question a couple questions ago, vote for the people who are going to focus on your personal health, not on the dollars spent on your personal health, but your personal health, and who care about the holistic you, and not what you represent and what your vote represents. So I would say that's one thing we can all do. But it's extremely disappointing, and just stepping away even from being a manufacturer, it's really challenging to understand which environments we're going to be existing in that support science and technology and moving progress forward, and the ones that are going to take it back a few notches. So what's unfortunately happening because of the polarization is we're going to have one administration that does this stuff, and the next one takes it back and does their own stuff, and then the next one's going to do what they need to do. And so, I don't have a solution. Just vote. There are governments that I've been talking to over the last 2 years. The people change in those governments because people did not like how they were responding to the pandemic, and it was a totally new administration. And it's happened a few times with some of the governments I've been talking to, and people are voting, and you do wonder about what are they valuing in their vote versus if they're valuing health.
Barbara, I want to make sure we talk about health equity, but before I switch topics there, was there anything you wanted to add about polarization and the impact that has had on this pandemic and how we learn from that for the next one?
I'll add just one small specific. It's not small, it's big, but it's a specific. I mentioned at the beginning that I moved to the Gates Foundation right at the beginning of the pandemic, and a year later I came back to CDC basically because I saw what was happening to this agency that is filled with people who I admire, respect. I know that they are the hardest working, smartest, best motivated people I've ever encountered. And I just saw what was happening to the agency, and I thought, well, I'm not going to be able to change anything, but maybe I can help a little bit. I went back. And to see the We've been talking a lot at this conference about the burnout of healthcare workers, the burnout of public health workers, the local public health workers at the state level, at the national level, and globally is unbelievable. There have been surveys of state and local public health workers that show that high proportions have received death threats, have most describe mental health problems coming out of the pandemic. And so as we're thinking about ways to support our healthcare workers, we need to be also doing that for our public health workers. When everything's going well, they're invisible. But in a pandemic, they're no longer invisible, and they've been really, really targeted and really hurt. So I think we need to, as society, to support them much better for now and for the next one.
Now, switching gears to health equity. Jana, I know this is a passion of yours, as it is mine. Talk to us a little bit about, the lessons we've learned from that health equity lens from the COVID-19 pandemic. I mean, we all saw that, especially towards the beginning, Black and brown communities were disproportionately affected by COVID. Many, many deaths as a result of it. We've also seen when it comes to access to vaccines as well, people in those communities didn't have the same kind of access in many cases as those in wealthier communities as well. So tell me a little bit about, from a health equity standpoint, what are we learning? How do we improve on that to make sure that whatever approach we have is equitable going forward?
Well, I'd like to follow up on Jane and say, vote for that, right? Vote for that. Vote for people who care about that. That will help. Though I've become through this process, I hope I get my juju back, but I've become very jaded about both sides of the aisle, and I have lots of reasons for that, included being in the stump speeches of our current administration, promising to do things that, with my project and others, that they didn't do, right? So I'm an independent now, or soon to be. But still, your vote matters. I do think, and because we're here, and why I came here, is that we have an opportunity, because I'm jaded about the political system and the motivations and that fixing anything, frankly. I feel like we need to support our agencies and the great people in them, and we need to change how we think about our own democracy and the way we live in our communities. So this conference brings high wealth individuals together with thought leaders. And I think that what we need to do is more of this. I think that if you are a high wealth individual, please join together with your local community-based organizations, those especially that focus on Black, brown, Indigenous, and LGBTQ+ communities that have very little to no voice, and yet are overrepresented in the impacts of these diseases. If you think about Mpox, during COVID, we had Mpox, and people really didn't pay attention to the community that was being impacted by that. If you know people, I think if you're here and you're a high wealth individual, you're doing it, right? But if you are going to social events with your friends, get them to do it too, please, please, because what I've seen in my travels as an international, almost health diplomat, is that our royalty in this country are wealthy people. I've seen royal gifts go back and forth between a princess and the Rockefellers. So this is, you have, the people with the most have the most power and the most access and can actually make the most get done. Maybe sadly more than our individual votes. And so I encourage those folks to get together with the underrepresented folks and change how we live in this country.
Thank you so much for that, Jana. Jane, what about you? From a health equity standpoint, how can we better prepare for the next pandemic?
Sure. So we, as Pfizer, have shipped over 4 billion doses of COVID vaccines to the whole entire world, and putting the corporate hat on, 1.8 billion of those have been to low middle income countries. So that's pretty good, but of course, we aim to do better. One of the reasons that I really enjoy working at Pfizer are our values: courage, excellence, equity, and joy. And equity is the starting point of where we want to begin any of these conversations. As an example, our CEO signed last year at the Davos an accord that committed to providing innovative medicines, which includes vaccines, at not-for-profit prices to many, I don't want to get the statistic wrong, many low-income countries of the world. And I think that's, we're trying to do better. We're not perfect, but we're trying to do better for sure.
And Barbara, anything to add on the health equity angle?
Yeah, I'm so glad I got my chance. I think we all know that the pandemic has shown a spotlight on the inequities in this country and around the world, but I'm going to focus on this country for right now. I was talking earlier about the importance of data, and I actually have a little bit of a success that I'd like to share with the group here. I think this kind of points to what we could do better next time. So early in the vaccination campaign, there were really significant inequities in who was getting the vaccine. And what happened at CDC was that an activity called Partnership for Vaccine Equity was stood up very quickly. This was back probably in the, just several months into the vaccination campaign, early 2021. And that organization, among other things, has given, granted tens of millions of dollars to community-based organizations serving communities that were of particular concern. We used our social vulnerability index, which looks at a whole range of factors, but including race and ethnicity, socioeconomic status, a range of factors that indicate whether a particular area is particularly vulnerable. And those areas and their populations were the community-based organizations were selected based on their ability to serve those populations. And what actually happened was the inequities were erased. The primary series, I don't know if people know this, but primary series vaccination for COVID in the US, it's about 85% for blacks and for whites. It's actually slightly higher in blacks than in whites. Mm-hmm. But that, it shows that by, I think that the data to see where the problem is, and to really see where it is, very specifically, and then the partnering with the trusted messengers who can make a difference, that we can make a difference by doing that. We did make a difference by doing that. So we should keep doing that.
Definitely. I want to get to some more audience questions. We have time for maybe one or two before my last one. The gentleman over there in the back, please. Wonderful. Thank you.
Yeah, excuse me. Nathan Chomolo, I'm a Medicaid medical director for the state of Minnesota, and I was the COVID vaccine equity director for Minnesota as well. And so I guess a lot of questions coming up here, but I think the one I'm going to land on is the disparities you talked about, and I'm glad the CDC stood up when they did. Those are predictable. I wrote a piece with colleagues from across the country in May of 2020 in Health Affairs that talked about colorblind allocation of resources is going to lead to worse disparities. And you look at all the frameworks that were put out by NASEM and WHO and others that talked about allocation of resources, scarce medical resources in a pandemic, they were largely not followed. So I guess I'm really wondering what is going to be different this time. How can we not wait for disparities to appear when we know they are going to in a society that's been structured along lines of race and other inequities, and actually kind of move forward with allocation equitably from the start?
Mm-hmm. Thank you so much. That was a great question. Would you like to take that, Barbara?
I think we needed to go back to Javier Becerra's talk before this, because I think you're talking a lot about healthcare, the healthcare system, and I think what I could do is agree with you. I don't, as CDC, we're public health, not healthcare. I don't have a lot of insight into the specifics that you're asking about there. I think that from the vaccine point of view, which we were involved with, I do think that there's lessons learned from that experience, and you're quite right. Wouldn't it have been good to not have to see those disparities emerging in February or March so that we would then need to do something about them? But I feel like this what I've said about the data, real-time analysis, and then the partnerships and health communications that allow you to do something about what you're seeing in the data, I feel like that's the core of making things better next time. Do you have other thoughts?
I don't, it's a challenging problem and it's a systemic issue. We know this. It's not just one thing. It's not just about putting the vaccines in certain communities. It's also, one of my colleagues is talking tomorrow about clinical trial diversity, making sure that we have people represented in trials as we're designing them, which is a really big difference compared to, we're talking about average age males and females, and it's got to be incorporated in the very beginning. So I think, there's a lot of work left to be done. It's not easy, but, we do commit that we're going to be trying to do better.
Great. Another audience question over here. I see this gentleman right here. Wonderful. Thank you so much.
If you're a pro-Biden person and you go out to dinner with a pro-Trump person, you know you're going to have a bad night. But if you go out to dinner with an anti-vax person, it's just as bad. And there's all these misconceptions out there. The government is not telling the truth where the virus started, that vaccinations cause people to die, that the measles crisis in Brooklyn a couple years ago didn't exist. There's a lot of this horrible information. There's even a school in Miami that you can't go there unless you're not vaccinated. It's a terrible situation. And I, for one, am looking for the federal government or for you guys to come up with some statements with real facts that tell the truth, because it's really hard to try to reason to someone who's got in their head that vaccinations cause autism without having any facts to support that. Any comments?
Yes.
I mean, the quick comment is the facts are there and we do put them out, but it's back to my earlier comment. It's boring. The way that we put it out. So we have amazing storytellers here at this conference. We need to find other mechanisms because, frankly, some of the kinds of people, if we're generalizing, that you're talking about don't want the facts, and you can talk to them about facts until they're blue in the face. And probably everyone here, in my own family, we had people on both sides of that, right? And I've seen families fractionated. One of my best friends, who is a virologist, that lead virologist on that project, her mother died of COVID, and her father, for some time, didn't speak to her because he didn't believe in COVID. Wow. So she said, I lost both my parents to COVID. So there's no fixing that at dinner. And there's no fixing that with a lovely research paper or even a beautifully, articulated, simple, bulleted list. It's not going to fix it. I'm sorry to say, but we're back to the systemic racism and the big, huge problems of society. That's what needs to be fixed if we're going to fix this, because it's really all perpetuating itself.
Jane, it looked like you wanted to
It's what you just said.
add.
You can't reason with these people. They have access to the same information, but why is one side resonating and not the other? It's a deeper issue.
Did you want
I have nothing to add.
Right, no problem. Yes, I see a question. I'll take that gentleman over there.
Good afternoon. Thank you so much. I greatly enjoyed the presentation. With many of the big problems, right, sometimes they cannot be solved, but a dent can be made. So are there like 2 or 3 maybe action items that you could recommend for local communities or people that want to be leading from that perspective? How would they partner with the federal government or with some of the groups that are here?
Wonderful. Yes. What are the action steps people can take away? Go right ahead.
Yeah, thank you. So I won't repeat the ones about data and systems and partnerships and ready-to-go contracts. There's another one that I think is really worth mentioning here, and that is ventilation. We have learned in this pandemic how important good indoor air quality is, if we didn't already know it. I think of it as the next step in the sanitary revolution. We cleaned up the water back in the early 20th century, the early 1900s, and in this country, controlled cholera and typhoid. We've cleaned up the food to a large extent, greatly improved food safety. It's time for us to clean up the air And that CDC has actually just, in the last few weeks, posted some, it's not guidance in the sense of telling people what to do, but it's sort of recommendations and advice about what people can do in homes or restaurants or offices, non-healthcare settings to improve the air quality, to reduce the risk of transmission of this virus or any other virus that might be in the air.
Right.
I would say take accountability for your own health. We used to be a society that when you got a cold, you went to work. And I would hope that that is something that maybe we've learned from and are not going to do that. If you don't feel well, take a test, stay home. And now we know that we have the infrastructure to be able to work from home, do what's needed. It's not ideal, of course, but I would hope that that is something that comes out of this pandemic that we all continue to carry forward.
And Jana?
Yeah, so education. I think communities need to advocate for changes in the school system, and we can all do that. We can do that at home. We can do that with our school boards. We can do it with the state standards to change science education. So I mentioned that, but I think it also goes into like my level university education. We need better pipelines for, frankly, Black, Brown, and Indigenous people to become healthcare workers, and because we know that people trust people more that look like them. So that is a huge push, and you can advocate for that in your communities. You can help kids get to school, get through school successfully, get into medical school or whatever discipline they want to go in. But I think it's critical that we need to just improve our pipelines for workforce and professionals so that communities see themselves in their caregivers.
Thank you so much. And with that, we are out of time. Jana, Jane, and Barbara, thank you, all three of you, so much for your insights here. And thank you all as well for the questions you asked and for being in attendance. Enjoy the rest of the Ideas Festival.
Thank you.